Hello, my dear colleagues. On behalf of the Cardiovascular Department of Cairo University, allow me to extend a warm welcome to you for joining this e-learning program. In the beginning, let me introduce myself. I am Dr. Hesham Yehia. I am an assistant professor of cardiovascular medicine, a member of the Cardiovascular Department in Cairo University. The scope of this lecture is intended to help the postgraduate students getting familiar with the cardiac devices, guidelines, and the use in modern cardiology with the future developments. First, let me start by giving you some historical background about the development of the cardiac pacemaker. By the late 19th century, a German physician known as von Zimsen had reported that the electrical impulse could activate the exposed human heart. And in the early 20th century, Mark Lidwell, he's an anesthetist at the Royal Prince Alfred Hospital in Sydney, had developed a device that delivered an alternating current through a needle that was inserted into the patient's ventricle. And he used this electrical stimulation and saved the life of a newborn child suffering from cardiac arrest at the Crown Street Women's Hospital in Sydney. And he reported this work to the Third Congress of the Australian Medical Society in 1929. 3 years later, an American physiologist, Albert Hyman, reported the use of the intracardiac injection of some stimulating drugs to restart the stopped heart. But actually it wasn't the drug that produced so, but it was the needle itself that was responsible for restarting the heart by starting or setting up an acute current of injury on the punctured myocardium. And Hyman called his invention is the artificial pacemaker. This resuscitation therapy had caused much controversy at the time, and Hyman had experienced significant oppositions from his colleagues. By the year 1949, at Toronto General Hospital, Wilfred Bigelow, together with his colleague John Callahan, had started using hypothermia to produce bradycardia and reduce the metabolism of the heart, so as to perform cardiac surgery. But rewarming did not restart the heart function quite rapidly. So they began the experiments with SA node stimulation. And in 1952, Paul Zoll, he's a Boston cardiologist, had developed a tabletop external pacemaker that can stimulate the patient with cardiac arrest through the chest. But this device produced skin burns, muscular contractions over the chest, and severe pain. A lot can happen in a minute, and a spark can trigger a life-changing idea for an inventor during this minute, and it might also take him to make huge mistakes. In some extraordinary cases, maybe both phenomena can occur at the same time. And this was the case of Dr. Wilson Greatbatch. He is the father of the currently available pacemaker. He, in just a minute, made an error that led to a life-saving invention and changed the cardiovascular healthcare. In the year 1956, he attempted to create a heart rhythm recorder. But after adding an incorrect electronic component by mistake, the device produced the electronic pulses instead of simply recording the sound of the heart. And this sound was similar to that made by the healthy heart. And he realized at this moment that the device could help an unhealthy heart to stay in rhythm by delivering shocks to the heart muscle to contract and pump blood. Currently, there are three primary classes of cardiac implantable electronic devices, which are the permanent pacemaker, implantable cardioverter defibrillator, or the ICD, cardiac resynchronization therapy, the CRT devices, either a pacemaker or in ICD, and the fourth type, of cardiac devices is out of the scope of this lecture, which is the cardiac assist devices. I'm going to start talking on each of these three primary classes of electronic devices. The pacemaker or the pulse generator has a power source. This power source is mainly of a lithium iodine cells, and it is connected to the microcircuit. This microcircuit controls the characteristics, functions, and timings of the generated impulse. This hole is encased in a tight-sealed titanium can, and this power source provides a lifespan of about 5 to 15 years depending on the complexity of the system, the programmed output, which features of the pacemakers are programmed on, and how much the generator is being used by the patient. The generator is connected to the myocardial tissue by the pacemaker lead, and this lead contains conductor coils. These coils are separated by an insulation material. The design of the coils in the leads is either of two types: a coaxial, meaning that there is a coil inside a coil, or co-radial, meaning that the two coils are arranged side by side. The tips of the leads had a variety of designs, and sometimes they are porous. Why? To improve the surface area of contact with the endocardium, minimize the development of inflammation and fibrous tissue, and will increase the pacing threshold later on. These porous tips increase the contact with the electrolytes and reduce the polarization voltage and promote the rapid tissue ingrowth. The tip of the leads is attached to the myocardium by either a penetrating helix, which is the active fixation, or by small tines or flanges that embed into the myocardial trabeculations, which is the passive fixation method. At the proximal end of the lead is the connector, and this connector pin is fixed by a screw mechanism to the pacemaker generator at the time of pacemaker implantation. The pacemaker is usually implanted for those patients with symptomatic bradycardias. And the primary indications for the insertion of pacemakers are mainly based on strong expert consensus, because they were mostly developed before the area of the randomized controlled trials. But in general, the most common indication for the implantation of a pacemaker are for the management of sinus node dysfunction, second and third degree AV blocks. This table shows the current guidelines for the insertion or the implantation of the permanent pacemaker. The pacemakers are classified by the nature of their pacing mode. So the classification follows the code that was developed by the North American Society of Pacing and Electrophysiology and the British Pacing and Electrophysiology Group. This code was last revised in 2002. Most of pacemakers are programmed to inhibit pacing when they sense the native electric activity and pace in the absence of this electrical activity. They can be programmed to set which chamber will pace and which chamber will sense the intrinsic activity, how the pacemaker will respond to the sensed electrical activity, and if rate-responsive pacing will be used or not. This code describes the pacemaker modes. The first column indicates the chamber being paced. The second represents the chamber being sensed. The third provides the pacemaker response to the sensed ventricular activity. And the fourth contains the letter R, and it indicates the rate adaptive or rate responsive pacing if it's being used or not. The rate responsive pacing responds to sensors in the pacemaker that increase the heart rate during physical activity. And the current available rate adaptive sensors are the accelerometers that respond to the movement and minute ventilation sensor that respond to the increase in the respiratory rate. Here in this table, we can see an examples of the different pacing modes. The first and the simplest of them is the asynchronous mode. in which the chamber paced is either the atrium or the ventricle or both. There is no sensing at all, and here it is denoted by the letter O, and of course there is no response to the non-sensing of the pacemaker, also denoted by the letter O. So we got a VO, AO, or DEO. The second one is the synchronous mode, in which either chamber, the atrium or the ventricle, or both chambers are paced and sensed. But the response to the sensing of the intrinsic activity will be either by inhibition of pacemaker firing or triggering the pacemaker to fire according to the intrinsic activity if it is sensed or not. And the later mode is by adding the letter R, and is the rate responsive mode to increase the heart rate in response to a sensed physical activity. The understanding of the various pacing modes and the paced electrocardiograms needs a full understanding of the pacemaker timing cycles, and these cycles include either sensed or paced events and periods when the sensing circuit of the pacemaker is refractory. The knowledge of the relation between the different elements of the paced ECG enhances the understanding of the pacemaker rhythm. Each of the timing circuits of the pacemaker can function in only one of two ways. When a given timer starts, it can proceed until it completes its cycle. This completion results in either two things: the release of a pacemaker stimulus if there is no native rhythm sensed, or the initiation of another timing cycles when sensing a native activity. So we have 5 scenarios for these timing cycles. We have the time from the paced ventricular atrial or ventricular beat to another paced atrial or ventricular beat, and the time from either paced ventricular beat to intrinsic ventricular beat when sensing a native QRS complex or a premature ventricular contraction, and the time from the intrinsic atrial beat to another paced atrial beat, and the time from the intrinsic ventricular beat to a paced ventricular beat. When a given timer can be reset, it will start the timing period again. Here are some abbreviations for the native and the paced events and portions of the timing cycles of the pacemaker. First is the P, which is the native atrial activity. The A is the paced atrial activity. R is the native ventricular activity. V is the paced ventricular activity. I stands for the interval. AV stands for the sequential atrioventricular pacing. AVI stands for the programmed AV interval. The AR stands for the atrial paced event followed by the intrinsic ventricular event. The ARP is the atrial refractory period. The PV is the native atrial depolarization followed by a paced ventricular event, which is called the P synchronous pacing. The atrial escape interval or the ventricular atrial interval is the interval from the ventricular sensed or paced event to an atrial paced event. Lower rate limit, upper rate limit, maximum tracking rate, maximum sensor rate, post-ventricular atrial refractory period or the PVARP, rate responsive AV delay, and the VRP is the ventricular refractory period. Here in this example, we start with the simplest form of all the pacing modes, which is the VO or ventricular asynchronous mode. There is no here sensing nor mode of response. The timing cycles of the asynchronous pacing consists of only a programmed rate, and the pacemaker delivers the ventricular pacing artifact at this programmed rate regardless of any intrinsic activities. And here in this example, we can see that an intrinsic QRS complex occurring after the second paced QRS complex. But because there is no sensing, so the interval between the second and third paced complex remains stable. The timing cycles cannot be reset because there is no sensing. And in the absence of this sensing, there is no defined refractory period, and this is very important. The atrial asynchronous mode, or the AOO mode, behaves exactly like the ventricular asynchronous mode, but the pacing artifacts occur in the atrial chamber. For the dual chamber asynchronous pacing, or AV sequential asynchronous pacing, the DEO mode, the pacing has also equally simple timing cycles. First, the interval from the atrial artifact to the ventricular artifact, which is the AV interval, and another interval from the ventricular artifact to the subsequent atrial pacing artifact, which is the atrial escape interval or the ventriculoatrial interval. Both intervals are fixed, and they never change because the pacemaker mode is insensitive to any atrial or ventricular activities, and as we said, the timers are never reset. The second type of the pacemaker mode, which is synchronous mode pacing, is a VVI. And by definition, the VVI pacing involves the sensing on the ventricular channel, and the pacemaker firing is inhibited by this sensed ventricular event. If there is no sensed ventricular activity, so the pacemaker will resume its firing again. The VVI pacemakers are refractory after either a paced or a ventricular event, and this period is known as the ventricular refractory period, and here it is represented by the shaded triangle. Any activity that happens during this period will not be sensed and does not reset the timing circuit of the pacemaker. In the absence of a sensed ventricular event, the lower rate timer is complete and a pacing artifact will be delivered. However, if an intrinsic QRS complex like a spontaneous or a premature ventricular contraction is sensed, so the circuit or the timer of the lower rate limit will be reset and it will restart again from that point. In the AAI mode, the timing cycles consists of a programmed lower rate limit and an atrial refractory period, acting just like a VVI mode. When the timer of the lower rate limit is complete, the pacing artifact will be delivered in the atrium in the absence of any native atrial activity. And if a spontaneous P wave occurs, the lower rate timer will be reset and started from that point. The atrial refractory period will begin with any sensed or paced atrial activity. In the AI mode, only the atrial activity is sensed. But when we look at the second figure, it is unusual to see a paced atrial activity immediately or soon after the occurrence of an intrinsic ventricular activity. Why this happened? This is because that sensing is happening only in the atrial channel and it does not have any relation with the ventricular activity. So the occurrence of any ventricular event would not be expected to reset the atrial pacemaker timing cycle. But when we look to the third figure, here is the lower rate limit is about 60 beats per minute or 1000 milliseconds. And the interval between the second and third paced atrial events is more than 1000 milliseconds. And the interval from the second QRS complex to the subsequent pacing artifact is 1000 milliseconds. This occurs because this QRS complex has been sensed on the atrial channel, and this is what we call a far field sensing, and this has inappropriately reset the timing cycle of the atrial pacemaker. In the rate adaptive or the rate responsive pacemaker, the sensor function of the pacemaker is the modulation of the pacing rate in response to a signal other than the presence or absence of the native or spontaneous activities. And mostly used sensors nowadays include the motion sensor, as we have said, either the acceleration or vibration, the impedance signals that measure the minute ventilation, and the QT interval sensors. The single chamber pacemakers that have the function of rate adaptation or rate modulation can be implanted either in the atrium or in the ventricle. And the timing cycles of these pacemakers does not differ from the other pacemakers which are not rate modulated. It includes both the basic VV and AA interval and a refractory period from the paced or the sensed events, as we have said before. The only difference lies in the variability of the VV or AA intervals. So, depending on the sensor incorporated and the patient's exertion level, the basic interval is shorter than the programmed lower rate limit, and this shortening requires programming another timing of the pacemakers, which is the upper rate limit, to define the absolute shortest cycle length allowable. At higher rates under the sensor drive, the pacemaker may act like a synchronous rate responsive mode because the alert period during which sensing can occur is very shortened, and the native beats that fall during the refractory periods will not be sensed. So, if the refractory period can be programmed, it should be programmed to a short interval just to minimize the refractory period and maximize the sensing period at both low and high sensor controlled rates. Some pacemakers, when this cycle length shortens, the refractory period shortens correspondingly, and this is referred as the rate variable refractory period. As we have said, it's a general rule that every pacemaker with sensing capability should have a refractory period in its timing cycles. This period prevents the sensing of inappropriate signals as the T waves from the inhibition of pacemaker firing. And we had seen in single chamber systems that is capable of sensing, each sensed or paced event will be followed by a refractory period. Once this refractory period ends, the amplifier will become alert and able to detect native signals again. The pacemaker acts like the heart and has a refractory period that consists of two parts. The first part is the absolute refractory period, during which any native activity cannot be detected, and this is called the blanking period. The terminal part of the refractory period is relative and events can be sensed, but these events are not used to trigger or reset the output of the pacemaker. They are used to detect rapid signals above the physiologic range, like for example 400 to 600 cycles per minute. Then the pacemaker will have a synchronous mode, and this called the noise mode response. In the dual chamber systems, those rapid events that are detected on the atrial channel but not on the ventricular one will help the device to detect the pathologic atrial rates like atrial fibrillation or atrial flutter or rapid atrial tachycardia, and will initiate an automatic mode switching or non-tracking mode for the pacemaker. The timing cycles of the dual chamber pacemaker consists of a lower rate limit, an atrioventricular interval, a ventricular refractory period, post-ventricular atrial refractory period, and an upper rate limit. And there are four variations of the DDD timing cycles. The first one here in the figure A in the first panel, if intrinsic atrial activity occurs before the termination or the end of the lower rate limit, so both channels will be inhibited and no pacing will occur. But if a P wave is sensed before the end of the ventriculoatrial interval, so the output from the atrial channel will be inhibited and an atrioventricular interval will be initiated. If there is no ventricular activity sensed before the termination of the atrioventricular interval, a ventricular pacing artifact will be delivered, and this is called the P-synchronous pacing here in the second panel. If no atrial activity is sensed before the termination of the ventriculoatrial interval, so a pacing atrial artifact will be delivered. That will initiate the atrioventricular interval. And if the intrinsic ventricular activity occurs before the termination of the AV interval, so the ventricular output from the pacemaker will be inhibited, and this is called atrial pacing ventricular sensing. And if no intrinsic ventricular activity occurs before the termination of the atrioventricular interval, so a pacing ventricular artifact will be delivered, and this is called the AV sequential pacing, here illustrated in the fourth panel. In dual chamber systems, the sensed or paced atrial event will initiate both an atrial refractory period and the AV interval. During this part of the timing cycle, the atrial channel is refractory to any other native atrial event, and atrial pacing cannot occur during this period. The atrial pacing can occur only at the end of the AV interval or after that. A sensed or a ventricular paced event will initiate the ventricular refractory period, and this ventricular refractory period prevents the sensing of the T wave on the ventricular channel of the pacemaker. And also, a sensed or a paced ventricular event will initiate another refractory period called the post-ventricular atrial refractory period, or a PVARP, on the atrial channel, not on the ventricular channel. This PVARP will prevent the atrial sensing of a retrograde P wave if there is intact retrograde VA conduction. The combination of the PVARP and the AV interval will form the total atrial refractory period. For example, if the AV interval is 150 milliseconds and the PVARP is 250 milliseconds, so the total atrial refractory period will be 400 milliseconds or 150 beats per minute. In this case, a paced ventricular event will initiate the 200 milliseconds PVARP, and only after this interval termination, an atrial event can be sensed. If an atrial event is sensed immediately after the termination of the PVARP, the sensed atrial event will initiate the AV interval of 150 milliseconds. On the termination of the AV interval, and in the absence of intrinsic ventricular activity, a paced ventricular event will occur, and this will result in a VV cycle length of 400 milliseconds or 150 beats per minute. The programming of a long PVARP limits the upper rate of the pacemaker by limiting the maximum sensed atrial rate. So if the native atrial rate, let's for example, was 151 beat per minute, so every other P wave would coincide with the PVARP and will not be sensed. So the effective paced rate would be dropped to the half and approximately 75 beat per minute. In pacemakers with mode switch algorithm programmed on, the pacemaker must be able to detect these higher atrial rates, even if the native P waves coincide with the PVARP. Although these P waves might not be tracked, the pacemaker is capable of monitoring the events that coincide with the refractory period and recognize the rapid pathologic atrial rates. Thus, the system at that time can switch from a tracking mode to a non-tracking mode, so that the first of the pathologic atrial event that occur during the atrial refractory period will not be tracked. When we look at the AV interval, we should consider it as a single interval with two parts. The whole AV interval corresponds to a programmed value, starting from the paced or sensed atrial beat till the next paced ventricular beat. And on atrial output, a timing period on the ventricular channel known as the ventricular blanking period will start. This period would coincide with the earliest part of the AV interval, and it is meant to avoid the sensing of an event or a stimulus of one channel in the opposite channel. So if an atrial pacing artifact is sensed by the ventricular sensing circuit, so ventricular output inhibition should result. And this is called the crosstalk. To prevent the crosstalk, the leading edge of the atrial pacing artifact will be masked or blanked by making the ventricular sensing circuits absolutely refractory during the very early portion of the AV interval. The second part is the crosstalk interval, and if ventricular sensing circuit senses any activity during this crosstalk sensing window, a ventricular pacing artifact will be delivered early, usually at 100-110 milliseconds after the atrial event, and this is known as the ventricular safety pacing. So to summarize this, the initial portion of the AV interval in most dual chamber pacemakers is designed as the blanking period. And during this portion of the AV interval, sensing is suspended. The primary purpose of this interval is preventing the sensing of the leading edge of the atrial pacing artifact. Any events that can occur during this blanking period, even if it is an intrinsic ventricular activity, will not be sensed. And in figure C here in this example, we can see that the premature ventricular beat that is not sensed is followed by the ventricular pacing artifact delivered at the end of the programmed AV interval and occurring in the terminal portion of the T wave. When we come to the hysteresis function of the pacemaker, hysteresis is known as a common phenomenon in physical systems and occurs when the system's output depends not only on its present input but also on the past inputs. So a pacemaker, which usually allows a longer escape interval after a sensed event, will give the heart a greater opportunity to beat on its own. Let me explain it further. On programming the hysteresis function on in the pacemaker will allow the prolongation of the first pacemaker escape interval after a sensed event. So a pacemaker programmed at a cycle length of 1000 milliseconds and a hysteresis of 1200 milliseconds will allow 200 milliseconds more for another sensed QRS to happen. If another QRS complex is not sensed, then the pacemaker will continuously stimulate the heart at the programmed rate of 60 beats per minute or 1000 milliseconds. This will occur until a second sensed event happens, and this will restart the timing cycles again. The advantage of hysteresis in the single chamber pacing modes is making it able to maintain the spontaneous AV synchrony as long as possible. And this feature may prevent the symptomatic retrograde VA conduction and the resultant pacemaker syndrome. The endless loop tachycardia or pacemaker-mediated tachycardia or circus movement tachycardia is not a portion of the timing cycles of the pacemaker. But to understand why it happens, you should be familiar with the timing cycles of the dual chamber systems. It is a re-entry arrhythmia in which the pacemaker acts as the anterograde limb of the tachycardia and the AV node acts as the retrograde limb. If there is uncoupling of the AV synchrony like what happens in ventricular premature beats, the subsequent ventricular event will result in retrograde atrial excitation if the VA conduction is intact. And if this retrograde P wave is sensed by the pacemaker, so the AV interval will be initiated. And on the termination of the AV interval and the maximum tracking rate intervals, the ventricular pacing artifact will be delivered, which could once be conducted again in a retrograde manner, and this will establish the re-entry mechanisms that will continue until it is interrupted by fatigue of the retrograde limb or by certain maneuvers that we'll be discussing in few seconds. The paced VV interval cannot violate the programmed maximum upper rate limit, and the endless loop tachycardia usually occurs at the upper rate limit. Many mechanisms have been taken to prevent or minimize the occurrence of the endless loop tachycardia. The first one by abolishing atrial signals through magnet application, and this will block the anterograde limb of the circus movement tachycardia. The second one is through blocking the retrograde limb by carotid sinus massage affecting the AV node or by giving AV node blocking agents as beta blockers or calcium channel blockers. Changing the pacemaker mode from tracking to non-tracking mode is one of the methods used to terminate the tachycardia, and changing the atrial sensitivity so as not to sense the retrograde P wave, which will be of a smaller amplitude, and this will help in minimizing the occurrence of the circus movement or pacemaker mediated tachycardia. The extension of the P-VARP also will help in preventing this kind of arrhythmia. Some pacemakers have the adaptive P-VARP in the rate responsive modes, and the shortening of the AV interval after a single beat to induce a retrograde VA block is one of the methods that can be programmed in the pacemaker. Also, some of the functions of the pacemaker, like dropping ventricular paced beats if the pacemaker is pacing at the maximum tracking rate for a specific period of time. All of these methods might terminate and minimize the occurrence of the endless loop tachycardia. Now we move to the second type of the cardiac implantable electric devices, which is the implantable cardiac defibrillator. We know that sudden cardiac death is a catastrophic common result of both acquired and genetic heart diseases, and the causes of sudden cardiac death differs widely among age groups. The overall number of sudden deaths due to coronary artery disease has declined over the past 50 years because of the coronary reperfusion strategies that led to the reduction in the acute mortality and minimizing the infarct size and scar burden, and thus reducing the arrhythmia substrates. In the Framingham Heart Study, there was 49% reduction in sudden cardiac death due to ischemic heart disease during the second half of the 20th century, and 48% of those who died suddenly had no evidence of coronary artery disease. In the Western countries nowadays, coronary artery disease remains the leading cause of death in the all age groups, accounting for about 70 to 80%. However, in the young, 35 years or less, the distribution of etiology is more different. Maybe the most striking feature is that about 40% of sudden cardiac death of them remains unexplained after complete assessment. When we look back at the invention of the ICD, it was Michael Mirovsky together with his junior colleague Morton Maurer who started to work on ICD at Baltimore. Both of them had a partnership with an engineer called Stephen Hillman, who had a small medical equipment company called Medrad. And this collaboration resulted in the production of the first ICD prototype, and it was small enough to be completely implanted in dog in 1975. Despite the success of this ICD model, it was a little bit heavy. It weighed about 225 grams, required a thoracotomy for the implantation of the electrode patches, and was only capable of defibrillation. The years following, there had been numerous advances in the ICD design. And in contrast to the pacemaker leads, the ICD leads have one or two shocking coils inside the body of the lead to allow for defibrillation. The ICD generator is generally bigger than the pacemaker generator to accommodate for the additional battery size and the electrical circuitry needed for the defibrillation function of the ICD. In contrast to the permanent pacing indications, the current ICD guidelines are based on solid data from multiple randomized controlled trials. At first, the ICDs were primarily implanted for secondary prevention of sudden cardiac arrests in those who survived sudden cardiac death from non-reversible cause. And after that, the results of the landmark trials that had shown the efficacy of the ICD therapy for primary prevention of sudden cardiac death in those patients with ischemic and non-ischemic cardiomyopathy have expanded the indications for ICD implantation. This figure here, which represents a summary of the current ACC/AHA guidelines for the use of the ICD therapy for the prevention of sudden cardiac arrest. The first published and largest of the secondary prevention trials was the Avid Trial. It enrolled over 1,000 patients between 1993 and 1997 in North America. Those patients were required to have one of the following: either resuscitation from near-fatal VF, syncope with documented sustained VT, or sustained VT with left ventricular ejection fraction of 40% or less and significant symptoms attributed to this arrhythmia. Those patients were randomized to receive either an ICD or antiarrhythmic medications, mostly amiodarone. And the study population were mostly whites, 87%, men comprised about 80% of them, with high prevalence of coronary artery disease in 81%. The mean age was 65 and the mean ejection fraction was 31%. Ventricular fibrillation was the index arrhythmia in nearly half of the patients. After a mean follow-up period of 18 months, fewer deaths were noted in the ICD group, with an average increase in life expectancy due to the ICD of about 2.7 months at 3 years. Two other smaller randomized trials were conducted outside of North America. The first was the CASH trial, which randomized about 300 patients resuscitated from cardiac arrest due to documented sustained ventricular arrhythmias between 1987 and 1996. Exclusion criteria included secondary causes, cardiac arrest within 72 hours of myocardial infarctions, presence of severe electrolyte disturbances, or use of pro-arrhythmic medications. Those patients were randomized either to ICD or antiarrhythmic medications, and at a mean follow-up period of 57 months, the crude death rate was about 36% in the ICD group and 44% in the antiarrhythmic group. Although the survival free of sudden cardiac arrest was significantly higher in those who were randomized to ICD, overall survival was not significant. The second trial, which is the SIDS trial, and enrolled more than 650 patients between 1990 and 1997. They were included if they had documented ventricular fibrillation, out of hospital cardiac arrest requiring defibrillation or cardioversion, syncope resulting from documented sustained ventricular tachycardia, or documented sustained VT at a rate of 150 beats per minute or more, causing pre-syncope or angina with low ejection fraction 35% or less, or due to syncope of undocumented etiology with subsequent documented spontaneous VT 10 seconds or more, or sustained monomorphic VT induced by programmed ventricular stimulation. Those patients were randomized either to ICD or amiodarone. And although the risks for adverse outcomes were lower in those treated with the ICDs, the difference was not significant. On pooled analysis of the secondary prevention trials, the ICD was associated with 50% reduction of arrhythmic death with the defibrillator and 25% reduction for all-cause mortality. The absolute reduction in arrhythmic death with the ICD was 7%. That corresponds to a number needed to treat of 15 to prevent one death at 2-year follow-up. And there was no observed effect on non-arrhythmic death. The survival benefit of the ICD was solid in sensitivity analysis and was consistent from study to study. Despite the survival benefit of ICD therapy in patients surviving sudden cardiac arrest, the overall morbidity and mortality remains high. The survival rate for ICD-treated patients in the Avid trial after 3 years of follow-up was 84%, and this was compared to 76% for those who were treated with antiarrhythmic medications, and the majority of deaths were related to cardiac cause. But in comparison with the data published from the National Cardiovascular Data Registry, those patients undergoing ICD insertion for secondary prevention, the survival rate in them was reaching up to 90% at 1 year and 84% at the second year. This difference in the outcome is likely in part due to the improvement in the use of goal-directed medical therapy for heart failure and coronary artery disease. When we look at the primary prevention trials in the ICD, the MEDIT-1 and MUST trials showed a significant reduction in arrhythmic death reaching up to 75%. However, in the Cabbage Patch trial, there was a trend to decrease risk of arrhythmic death with the ICD, but it was not significant. When the results were pooled, there was a significant reduction in arrhythmic death favoring the ICD, but there was no excess of non-arrhythmic death in the ICD. And regarding the all-cause mortality, MUST, MERIT-1 and MERIT-2 trials showed a significant reduction in all-cause mortality with a relative risk reduction ranging from 29 to 59%. And the pooled data showed a significant benefit in favor of the ICD with a risk reduction of death from any cause of about 34%. Although the ICDs are highly effective in terminating life-threatening ventricular arrhythmias, the ability to identify those patients that may get benefit from these devices is still poor. In the coming few slides, I will try to illustrate the group of patients who might get the benefit from these devices. On looking to the results of this trial that was published in 2008, over a long period of follow-up of more than 500 patients with previous myocardial infarction and poor left ventricular function who had an ICD inserted for primary prevention, about 22% of the patients had received appropriate ICD shocks for ventricular arrhythmia, and the mean time from the ICD implantation to the first shock therapy was about 10 months. The annual rate of the appropriate shock therapy for ventricular arrhythmias was high in the first year and dropped in the second, but remained relatively stable in the years after at a rate about 6 to 11%. The annual rate of the appropriate shocks for life-threatening ventricular arrhythmias was also highest in the first year, decreased in the second year, and remained stable thereafter. So we can see that the risk of the appropriate ICD therapy for ventricular arrhythmias and life-threatening ventricular arrhythmias is not evenly distributed over time, being highest in the first year after implantation. So even in those patients who have survived more than 5 years after the ICD implantation without appropriate shock, there is still a risk of therapy for ventricular arrhythmias. And this persistent risk for ventricular arrhythmias several years after implantation might reflect the random nature of the occurrence of the ventricular arrhythmia or due to changes in the arrhythmic substrate that is affected by the clinical events such as myocardial infarction, worsening heart failure, or medication changes. Whatever the mechanism is, the present observation suggests that the freedom from ventricular arrhythmias after years does not indicate a negligible risk for future ventricular arrhythmias, and ICD generator changes should still be recommended in those patients. On looking to another point of increase in the mortality with the ICD therapies, a single ICD shock is associated with about 2 to 5 folds increase in the mortality, and progressive heart failure is the most common cause of mortality in those patients. The ICD therapies are classified as appropriate, inappropriate, avoidable, and phantom. The inappropriate shocks, which are typically caused by supraventricular arrhythmias, are frequent despite the detection algorithms that have been designed to differentiate between the supraventricular from ventricular arrhythmias. Up till now, the best method for programming the ICD devices to reduce these inappropriate therapies is still unknown. Here in this trial, the Avid Trial, 1,500 patients with primary prevention indication were assigned to receive an ICD with one of 3 programming configurations. The objective was to determine which type of therapy is associated with decreased number of patients with inappropriate shocks compared to the conventional therapy. The patients in the conventional therapy group had about 30% probability of inappropriate therapy at 2.5 years. And this rate was much less in both the high rate and delayed therapy groups, reaching up to 6% in the same follow-up period. On looking on the survival analysis, all-cause mortality was much higher in the conventional treatment group compared to the high rate and delayed therapy group during the follow-up period. And in comparison of the first occurrence of inappropriate therapy in the high rate group with that in the conventional therapy group, there was 78 or 79% relative risk reduction. And the risk reduction was about 76% in the delayed therapy group versus the conventional therapy group. The mortality was reduced by about 55% in the high rate group and 44% in the delayed therapy group, and the frequency of the first episode of syncope was similar in the treatment arms. The early studies of the ICD had focused on the patients at high risk for sudden cardiac death, especially those with a high event rate. So, the short-term follow-up could demonstrate a significant mortality benefit. But nowadays, about 70% of the ICDs are implanted for primary prevention, and those patients are often at the lower end of the risk spectrum. The high-risk patients will have the clearest yearly benefit from the device, but as many of them have heart failure and they die for other reasons than arrhythmias, so the average lifespan gain might not be that large. On the other hand, lower risk patients might have a low rate of non-arrhythmic death, and so they will have a much longer exposure to the risk of arrhythmia, even if they have a lower annual rate. And so the extent of survival benefit may not be that clear during the relatively short time period of most trials. Another point that the trials have focused on recruiting patients with dominant cardiac disease and excluded those with severe comorbidities. In clinical practice, patients with severe heart failure often suffer from multiple comorbidities and are at an increased risk of sudden death due to pump failure, which is a non-arrhythmic death. And this might discourage the ICD implantation. These graphs shows the 13 landmark trials for primary and secondary prevention. The size of the trial population is represented by the area of the marker. Across these 13 studies, there was a close relationship between baseline mortality and lifespan gain from the ICD at 3 years, with the trials that have a higher baseline annual mortality rate demonstrating greater lifespan gain. This relationship was similar within the primary and secondary prevention trials, suggesting a consistent relationship between the baseline mortality and lifespan gain within the population studied. The average weighted lifespan gain at 3-year follow-up was 1.5 months for the primary prevention trials and 2.2 months for secondary prevention trials. The overall was 1.7 months. The lifespan gain can be observed directly from the trial data, but because of the short duration of most of the trials, this had led to the underestimation of the patient's total lifespan gain. Here in this trial that was published in the European Heart Journal 2015, Raphael and his colleagues had developed the survival modeling that allowed the estimation of lifespan gain from an intervention over a much longer period of time. Of course, this cannot replace the real-life long-term follow-up data, but it has the advantage of being able to control for the effects of an intervention and other factors like non-cardiac disease. For the short duration of most of the landmark clinical trials of 3 to 5 years follow-up, those patients who had the greatest lifespan gain are those at highest risk for having a defibrillator preventable event. And the lower risk population had a little benefit over short-term follow-up due to their low event rate. In these patients, it's only the lifetime follow-up that will reveal the true benefit from the ICD. In this analysis, Raphael and his colleagues suggested that in the low-risk patients, that lifespan gain may be up to 9 times greater after 10 years follow-up than after 3 years. And this has a large clinical implication as the majority of the ICDs now are being implanted in the lower risk group for primary prevention. Looking on the economic analysis, the analysis is more dependent on the per ICD metric for the lifespan gain, but the per patient data are more relative for day-to-day clinical practice. So for lifetime analysis, lifespan gain per device is greatest at the higher risk patients because of the lower number of replacement the device required. But the lifespan gain per patient was greatest in those who in the lower risk group. And this suggests that the presentations of benefits or financial benefit and analysis of cost effectiveness should include both values and not depend on one value. There are multiple reasons why ICD implantation nowadays may be able to deliver more benefit in the lifespan than the calculated using the data from the original landmark trials. First, that most of the trials are now over 10 years old and therefore do not collect the effects of the improved clinical practice that have occurred since then. Like the minimization of right ventricular pacing, implantation of more CRTDs in eligible patients, etc. And by reducing also the risk of death from pump failure, this might potentially increase the benefit from the ICD implantation. The second is that there are modern refinements to the ICD programming on the use of the anti-tachycardia pacing and defibrillation, thus reducing the episodes of therapy, which has been shown to improve mortality. The third, that there is no randomized controlled trials till now that focused on patients with channelopathies or purely genetic arrhythmias. These conditions, which can be diagnosed at a young age, are associated with little or no comorbidities, will likely generate a longer period of follow-up and permitting a larger lifespan gain than calculated here in these trials. Lastly, the modern ICD is have a growing capacity for home monitoring, feedback information on the episodes of tachyarrhythmias, anti-tachycardia pacing episodes, changes in the impedance, etc., etc. This wealth of information may assist the physicians to improve the outcome further. There are few basic defects noted in the risk prediction tools used nowadays to determine the need for the ICD. First, most of the risk stratification approaches depend predominantly on the ejection fraction. It's affected by the loading conditions and is mainly based on some geometric assumptions that allow the quantification from 2D measurements. So it affects the reproducibility and accuracy of the measured value. And in addition, the ejection fraction itself represents the condition of a cardiomyopathy, but not necessarily the tendency towards arrhythmia. And here in this meta-analysis of 20 studies, including more than 7,000 patients, the sensitivity of the ejection fraction for significant arrhythmia events was 59% and the specificity was 78%. The initial studies, including the CAT and the AMIOVER trials that were randomizing ICD versus antiarrhythmic medications in those patients with non-ischemic cardiomyopathy and low ejection fraction, didn't show any mortality benefit. And in the larger definite study that evaluated the impact of non-ischemic cardiomyopathy patients with both non-sustained ventricular tachycardia and poor ejection fraction, despite it showed a 35% decrease in overall mortality in the ICD group, This result did not reach any statistical significance. These initial studies were followed later on by the large multi-center sudden cardiac death in heart failure trial that included patients with ischemic and non-ischemic cardiomyopathy with ejection fraction less than 35% to either receive placebo, amiodarone, or ICD. Compared to placebo, the ICD group was associated with about 7% absolute reduction in the all-cause mortality after 5 years of follow-up. But it was not significant in the analysis of the non-ischemic cardiomyopathy patients. After the publication of this trial, and in the year 2005, a pooled analysis of non-ischemic cardiomyopathy patients from the primary prevention trials showed a 31% statistically significant reduction in all-cause mortality for the ICD. In the recently published Danish trial in 2016, this trial was conducted in response to the limited evidence of the ICD benefit in patients with non-ischemic cardiomyopathy. It was the first ICD trial to require high proBNP level despite the optimum medical treatment. After a median follow-up of about 5 years, the all-cause mortality occurred in 21% of the ICD group and 23% in the control group. Of course, this was not of statistical significance. However, in a specified analysis from this study, a survival benefit from the ICD was seen only in those individuals less than 70 years of age. They had about 30% reduction in mortality in the ICD-R. Those who are above 70 years of age, the rate of non-sudden death was twice as high compared with the younger population, and there was no mortality benefit seen with the ICD implantation. Because of this age interaction, the widespread use of the cardioprotective therapies like CRT and the overall lack of mortality benefit to prophylactic ICD, the clinicians now are evaluating the evolution of heart failure management, the ICD implantation, risk assessment in non-ischemic cardiomyopathy. The introduction of the CRT has resulted not only in the improved mortality, but also in improved mortality. We can see here in the companion trial, both CRT with a pacemaker function only and that with the defibrillator demonstrated a similar reduction in the mortality risk. The addition of primary prevention defibrillator over CRT pacing is beneficial in well-selected patients with ischemic cardiomyopathy, but it does not carry a significant survival benefit in those with non-ischemic cardiomyopathy. Despite this, the Heart Rhythm Society guidelines still continue to recommend the prophylactic use of ICD in patients with non-ischemic cardiomyopathy, poor ejection fraction 35% or less, and function class 2 to 3 heart failure despite the optimum medical treatment. In non-ischemic cardiomyopathy, the substrate and cause often vary a lot, and as a consequence, the outcome is much less predictable. So the broad inclusion of all of these cardiomyopathies into one group with a common exclusion criteria of lack of significant coronary artery disease would explain the reduction in the long-term ICD benefit and overall less predictable outcomes. This second assessment defect for the ICD requires that risk assessment should be individualized towards each patient separately. In a recent analysis of 12 heart failure clinical trials throughout the last 2 decades and including over 40,000 patients, the investigators had demonstrated a 44% reduction in the sudden cardiac death rates. The annual rate of sudden cardiac death had decreased from 6.5 in the earliest trials to 3.3% in the recent heart failure trial, Paradigm Heart Failure. And this decline was parallel the increasing use of the evidence-based medicine, like the beta blockers, the ACE inhibitors, etc., etc. Furthermore, the proportion of sudden cardiac death relative to the overall mortality didn't change across the different trials, indicating that the fall rates of sudden cardiac death were in line with the downward trend in the overall death rates. As we've seen the importance of the risk stratification of patients with heart failure for sudden cardiac death, and we have discussed the present defects that is present in the current assessment, so I think it's very important to have another precise way for risk assessment of those patients. There are two developed risk score assessments for the prediction of all-cause mortality and the mode of death. And these are the Seattle Heart Failure Model and the Seattle Proportional Risk Model. The combined use of these scores for the risk stratification in the IC candidates is very important. And when we look at the survival curves for patients with different levels of scores in those with and without an ICD, it seems that the ICD had a clear benefit in the patients with both a low predicted 1-year mortality and a high predicted proportional risk of death, but not in those with low predicted 1-year mortality and low predicted proportional risk. Among those patients with the high predicted 1-year mortality and the higher predicted proportional risk of arrhythmic death, the improvement in the 5-year survival with the ICD was greater than those who have a low predicted proportional risk of arrhythmic death. And also in the patients with lower predicted overall mortality and the lower predicted proportional risk of arrhythmic death, this would have a minimal improvement in their life expectancy with the ICD during their lifetime. So patients would need to be treated for about 22 years with an ICD to add 1 year of life. On the other hand, those patients with a lower predicted overall mortality and a higher predicted proportional risk of death would have a life expectancy improvement of about 3.3 years resulting from the ICD, and those patients would only need to be treated for about 4 years to add 1 year of life. So the application of these models in a large number of patients that are candidates for the ICD could improve the ability to target the treatment to the right patient. There are several potential applications of clinical risk assessment for ICD primary prevention. The decision of an ICD implantation must be reviewed carefully because it commits the patient to an invasive treatment strategy. This includes repeated device-related procedures, potential complications, and reduced quality of life from the shock-related pain. The general cardiologist could use decision support algorithms before referring the patient to the electrophysiologist, just to enable the use of more information and sharing the decisions about the risks and benefits from the ICD. And here in this theoretical model, patients who are at low risk of appropriate shock and high risk of death in the first quadrant could go into discussions with their physicians to potentially avoid the ICD implantation. And among those who are at low risk for an appropriate shock, but not at a high risk of death in the second quadrant, there may be an opportunity or a chance for optimizing medical treatment and reassessing the degree of left ventricular ejection fraction recovery and re-evaluation of the decision to implant the ICD at subsequent annual visits. Finally, in addition to the current approach for risk assessment through the clinical characteristics and echocardiographic assessment, a more sophisticated approach for determining the prognostic value of the electrophysiologic tests like the electroanatomical mapping, T-wave alternance, signal average ECG, and the biologic markers and the advanced imaging modalities have been proposed for risk stratification of ICD candidates. The third type of the cardiac implantable electronic devices is the CRT, or cardiac resynchronization therapy. In several research findings, the role of the intraventricular conduction delay and the associated electrical dyssynchrony on the natural history of systolic heart failure had been identified. The CRT consists of simultaneous pacing from both ventricles and can be incorporated either in a pacemaker or a defibrillator. The pacing ICD lead is placed in the right ventricle, and another pacing lead is placed in the region of the left lateral wall of the left ventricle, guided through the posterolateral tributary of the coronary sinus. The role of resynchronization therapy in patients with congestive heart failure was first highlighted in the CARE heart failure and companion trials. The CARE heart failure trial had randomized more than 800 patients with heart failure functional class 3 to 4 with an ejection fraction 35% or less and a prolonged QRS complex for either a CRT or medical treatment. And the companion trial randomly assigned a similar number of population into three groups. One as medical treatment, the other is CRT alone, and the last one is the CRT plus defibrillator. The two studies showed a significant reduction in the total mortality or hospitalization as about 20 to 37% in the patients who underwent CRT insertion. The selection of patients who are going to benefit mostly from the resynchronization therapy depends mainly on the severity of symptoms and on the electrocardiographic criteria that indicates ventricular dyssynchrony. To qualify for resynchronization therapy, the patient must be on guideline-directed medical treatment for more than 90 days and more than 40 days post-myocardial infarction. A wide QRS complex is the marker of electrical dyssynchrony, especially in those with left bundle branch block pattern. And this is the most powerful predictor of response to the CRT. All of the randomized controlled trials enrolling patients for CRT with minimal QRS complex duration of 120 to 150 milliseconds have shown improvement in heart failure symptoms and survival. The wider the QRS complex, the greater will be the likelihood of response. The current guidelines recommend resynchronization therapy in patients with chronic heart failure and impaired left ventricular ejection fraction 35% or less, and who remain in New York Heart Association classification functional class 2, 3, or ambulatory 4, despite the optimum medical treatment, and those with typical left bundle branch block morphology with a QRS complex duration of 150 milliseconds. A lower strength of recommendation appears when the QRS duration is between 120 to 150, and those patients with non-left bundle branch block morphology should be considered only for CRT when the QRS duration is 150 milliseconds. Here in this table, we can see the different studies of resynchronization therapy in the patients with heart failure with reduced ejection fraction. We can see that the indications for the CRT and the ICD overlap in the majority of patients with severe heart failure. And the role of the CRT in addition to the ICD was demonstrated in the companion trial and was confirmed in the subsequent draft, reverse, and the MADID CRT trials. In the MADID CRT, there was about 40% reduction in heart failure events that was observed in those with the CRTD arm than in those with the ICD only arm. And in the RAFT trial, the total mortality was reduced by about 30% in CRTD arm versus the ICD only group. Of course, the clinical and echocardiographic criteria for the diagnosis of heart failure patient is not debatable, but the definition of complete left bundle branch block has been extensively discussed. Under normal conditions, the myocardium is activated by a uniform high-velocity electrical waveform that propagates through the His-Purkinje system and the bundle branches, resulting in synchronized depolarization of both ventricles. In those patients with left bundle branch block, the ventricular activation starts first in the right ventricle as the right bundle is not affected. Then it proceeds from the right ventricular endocardium to the left ventricular endocardium through the interventricular septum. Then the wave front propagates to the endocardium of the posterolateral left ventricular wall, and then it completely activates the ventricle without the use of the Purkinje system at all. So in the presence of complete left bundle branch block, there is a significant delay between the activation of the interventricular septum and the activation of the left ventricular flea wall. This will result in a QRS duration of 140 milliseconds. So in patients with left ventricular systolic failure and left bundle branch block, this delayed electrical activation will lead to delayed mechanical activation of the left ventricle, and in turn results in atrioventricular intraventricular dyssynchrony and reduction in left ventricular contractility, and later on will result in left ventricular remodeling over time. So the theory behind the CRT now is aiming to correct the mechanical dyssynchrony. by pacing both ventricles near simultaneously. This will improve the left ventricular function and over time might cause reverse remodeling. We know that the conventional diagnosis of left bundle branch block is based on the ECG criteria. Typically, prolonged QRS duration more than 120 milliseconds and QS or RS configuration in V1. But in about one-third of the patients who were diagnosed to have left bundle branch block were shown not to have complete left bundle branch block. And this reveals that there is a lack of a gold standard for the true diagnosis of left bundle branch block. And in fact, this high false positive rate of the conventional criteria that might limit the effectiveness of the CRT for treating those patients with heart failure. Later on, a difference in the QRS complex duration between men and women with left bundle branch block was found, and different simulation studies had evidence the presence of a mid-QRS complex notches or slurs in some leads when complete left bundle branch block is present. These observations had led to the definition of a new stricter criteria to diagnose left bundle branch block, and they require three simultaneous conditions. Number one is a prolonged QRS complex duration, 140 milliseconds or more in men or 130 milliseconds or more in women, a QS or RS pattern in the QRS complexes at the anteroseptal leads V1 and V2, the presence of mid-QRS complex notches or slurs in two of the leads within V1, V2, V5, V6, 1 and AVL. The mid-QRS complex notches or slurs should be 40 milliseconds after the onset of the QRS complex and before 50% of the global QRS duration. These notches or slurred R wave represents the delay of propagation of the depolarization wavefront to reach the endocardium of the left ventricle. This is the first notch, and the epicardium of the posterolateral wall. This is the second notch through the ventricular myocardium instead of conducting through the rapidly conducting Purkinje system. Here in this figure, we can see the isochron maps of normally activated left ventricle and activation of the left ventricle in the presence of left bundle branch block. The isochron map is a display of the distribution of ventricular activation times. And by definition, an isochron is a line drawn on a map connecting points at which something occurs or arrives at the same time. So in endocardial mapping studies, almost one-third of left bundle branch block patients have two left ventricular endocardial breakthrough sites. And these are consistent with two of the three break sites described in the normal hearts. What is a breakthrough site? The left ventricular endocardial breakthrough site is defined as the earliest location identified on the three-dimensional color map from which the activation consistently spread away to all parts of the left ventricle. And the normal sites of breakthrough are in the middle inferior septum, the anterior wall in the area of the insertion of the anterior. On looking to the response to resynchronization therapy, most patients from the randomized controlled trials have shown a benefit either clinically or echocardiography in response to the implantation of the CRT. However, one-third of the patients with a CRT did not show any benefit at all, and this group of patients are called the non-responders. There is no standard consensus on the definition of response and non-response. Some physicians use the clinical parameters like the mortality, heart failure, hospitalization. Others would use echocardiographic measurements like the increase in the ejection fraction or decrease in the left ventricular end-systolic volume. Others would use a combination of both parameters. It is uncommon that there is a discrepancy between the clinical and echocardiographic response as well. Here in an example is the response of the CRT in patients with ischemic heart disease. Those with previous myocardial infarction are known to demonstrate less echocardiographic response or remodeling after the CRT despite the clinical improvement in their symptoms. And the response to CRT as well is a very relative measure. Apart from the non-responders, the patients may stabilize their cardiac function and the clinical course, and they are previously grouped as non-progressors. The lack of improvement in the ejection fraction or the clinical status after the CRT implantation may lead the physician to distrust the CRT as an important tool to reduce the morbidity and mortality. And this led to the observed lower than expected implementation rates of CRT. We also tend to forget that heart failure is a chronic progressive malignant disease, and the stabilization of its course indeed might be a significant benefit of the CRT for this vulnerable type of population. On the other hand, some patients might exhibit a huge benefit of the CRT and even might normalize their left ventricular function, and they are grouped as the super responders. We should make every effort to achieve the maximum benefit from the CRT device. Although the echocardiographic assessment of ventricular dyssynchrony is not a reliable parameter to predict the outcome to the CRT, the pre-implantation imaging may become more important to identify the optimal position of the left ventricular lead. During the implantation of the CRT, it is crucial to place the lead, if possible, at the site where the longest electrical delay to potentially offer a higher level of resynchronization. Also, the optimal device programming by experts in device follow-up is essential to provide the maximum benefit. And even though routinely optimizing the device intervals after implantation hasn't been shown to be of clinical benefit, it may be important in those who are non-responders or negative responders and who are those experiencing clinical events and complications. And also the device-based algorithms now available to optimize the CRT response as the adaptive CRT might become more important in the near future. In addition to the biventricular pacing, other pacing techniques are still under investigations, which might potentially improve the outcome of the patients with heart failure. One of them is through His bundle pacing, and which will be discussed later on. Because the synchrony is the underlying substrate for resynchronization therapy, it has been postulated that pacing from more than one left ventricular site might improve resynchronization and the outcome. Multi-site pacing using two or more left ventricular leads and multi-point pacing using one multipolar left ventricular lead have been shown to be effective in improving the CRT response. In small randomized trials, the use of two epicardial coronary venous leads compared with one improved the acute hemodynamic response, ejection fraction, left ventricular end systolic volume, and symptoms of heart failure. Here, the data from the Italian registry on multi-point pacing in CRT showed improvement in the ejection fraction with multi-point pacing using a quadripolar left ventricular lead. And this effect was observed in patients with left bundle branch block with a wider QRS complex duration more than 150 milliseconds of non-ischemic etiology. The implantation of the two left ventricular leads also had been shown to be safe in short term. But on the long term, the failure rate is high due to the inability to chronically capture the ventricle using the Y adapter to pace simultaneously from the two leads, and also because of the rapid battery depletion. So the quadripolar leads offer the advantage of multiple programmable pacing vectors, thus minimizing the chance of lead neglection due to the high pacing threshold or the phrenic nerve capture, and the ability to choose the pacing vector with the best hemodynamic response and the capture a large area of the left ventricular myocardium by a pacing from a widely spaced electrode are potential explanations for the observed improvement in those with quadripolar leads or multipolar leads. Right ventricular pacing is known to cause electrical and mechanical dyssynchrony, and over the long term, it is associated with a higher incidence of heart failure and pacemaker-mediated cardiomyopathy, especially in those patients with greater than 40% of right ventricular pacing all over the time. The recognition of these hazardous effects of right ventricular pacing has led to a continued search for other alternative sites for pacing. Permanent His pacing was first described in the year 2000 in a small series of patients with atrial fibrillation and dilated cardiomyopathy, and the feasibility and safety of this technique has been demonstrated later on by several investigations. Permanent His pacing is a physiologic pacing alternative to the right ventricular pacing, and the depolarization of the ventricles is through the His-Purkinje system. So it will induce normal synchronous ventricular activation and therefore avoids the dyssynchrony that is caused by right ventricular pacing. Here in this study that was published in the JACC 2018, we can see that his bundle pacing was associated with reduction in the combined endpoint of death, heart failure hospitalization, or upgrade to biventricular pacing compared to right ventricular pacing in those patients who are requiring permanent pacemaker. The benefit of resynchronization therapy in patients with sinus rhythm is clear. However, about 25% of the patients eligible for CRT have atrial fibrillation. During atrial fibrillation, there is loss of atrioventricular synchrony and the inadequate biventricular capture. That will reduce the CRT effectiveness. The experience in randomized trials of CRT in patients with atrial fibrillation is limited. The MUSTIC trial had reported improvement in both functional status in patients with both atrial fibrillation and sinus rhythm. However, in a meta-analysis of observational studies, a greater mortality risk and a higher rate of non-response to the CRT in atrial fibrillation was observed compared to those with sinus rhythm. The current guidelines recommend the insertion of CRT in patients with atrial fibrillation, heart failure, ejection fraction of 35% or less, and a QRS complex duration of 120 milliseconds or more. It is very critical to control the ventricular response in atrial fibrillation so as to provide more than 99% biventricular pacing. It's very difficult to achieve that with medical treatment only. So the routine use of AV nodal ablation would ensure adequate biventricular pacing in those with atrial fibrillation. However, the potential benefits must be balanced against the risks associated with creating pacemaker dependency. In a recent study on 52 heart failure patients who had AV nodal ablation and His bundle pacing for symptomatic atrial fibrillation, there was a significant improvement in the echocardiographic parameters. This magnitude of improvement in the ejection fraction and left ventricular end diastolic dimension was significantly correlated to the baseline severity of left ventricular function. So the lower the left ventricular ejection fraction and the larger left ventricular end diastolic dimension at baseline, the greater will be the improvement in the ejection fraction and end diastolic diameter after His bundle pacing. We have discussed before the deleterious effects of right ventricular pacing on left ventricular function with the resultant heart failure in those patients who need prolonged right ventricular pacing more than 40% of all the time. Several studies with a crossover design have evaluated the upgrade from a conventional pacemaker to biventricular pacing in patients requiring permanent or frequent right ventricular pacing for bradycardia who have symptomatic heart failure or low ejection fraction. Here in this graph in the block heart failure trial, patients with AV block who require pacing and having ejection fraction less than 50% and functional class 1 to 3 heart failure, biventricular pacing reduced the combined endpoint of mortality, intravenous therapy of heart failure, and reduction in left ventricular systolic volume compared with right ventricular pacing only. So biventricular pacing can reasonably be considered in the patients who are anticipated to acquire a high percentage of ventricular pacing and have a low ejection fraction with mild heart failure symptoms. The ideal site for left ventricular pacing is still a subject of debate. However, it's clear that the closer the left and right ventricular electrodes, the lower will be the potential for resynchronization. So by maximizing the distance between the two electrodes in the horizontal plane, either in the lateral or left anterior oblique view, will be associated with a better response to the CRT. Apical positions are not that attractive because they result in less separation between the right and left ventricular leads, and also will lead to a non-physiologic ventricular activation from the apex to the base. This was supported by a randomized trial that showed a worse outcome with apical pacing sites. The preferential sites for pacing the left ventricle are the posterior and lateral positions. We can also measure the site of latest electrical activation using the timing of the local left ventricular electrogram that was recorded during the lead implantation. So as the left ventricular lead moves within the coronary sinus, we record the greater time interval between the start of the QRS complex and the local electrogram. The longer this interval, the more favorable acute hemodynamic response, the more favorable long-term reverse remodeling, and the more favorable improvement in the quality of life. Although all CRT devices has been delivered through the epicardial electrodes, the epicardial left ventricular pacing introduces multiple mechanisms of non-response, including the unsuitable coronary venous anatomy, lead dislodgement, phrenic nerve stimulation, and the non-physiologic epicardial to endocardial activation. The endocardial left ventricular pacing might allow for pacing from any left ventricular site, and it results in a narrower QRS complex and improved acute hemodynamic function as compared with epicardial pacing. The endocardial pacing may be preferred because of greater flexibility in selecting the site of implantation of the lead, the absence of phrenic nerve stimulation, and the more physiologic activation of the left ventricle. It can be done by using the conventional leads that are placed transapically or transseptally, but these techniques have been abandoned by some physicians because of the risk of systemic embolization and mitral valve insufficiency. Now the leadless left ventricular electrodes are under development and have shown benefits in reducing these complications. As we have seen, there are several methods used to characterize the position of the left ventricular lead to determine its effect on the response of the CRT. First is the anatomical left ventricular lead position. The second was the left ventricular local electrogram timing. And the third that will be discussed in this slide is the mechanical delay or scar assessment at the left ventricular lead site. The optimal left ventricular pacing sites are those with the latest mechanical activation, and the undesirable sites are those with scarring. That will limit the amount of left ventricular myocardium captured by the pacing stimulus. With the use of speckle tracking and the use of the backscatter, we can track the motion of specific myocardial segment. In the randomized controlled target trial, they found a reduction in death and heart failure hospitalizations in patients with left ventricular lead placement at the sites of latest activation that was identified by using the speckle tracking. And in the starter randomized controlled trial, the patients with QRS complex width 120 to 149 milliseconds and non-left bundle branch block morphology were most likely to benefit from echocardiography guided lead placement. Of course, cardiac magnetic resonance imaging may be useful as well because it will localize the site of late gadolinium enhancement, which indicates a scar formation, and we know that pacing from the sites of scarring will increase the mortality. Several recent studies have shown that there is a subgroup of patients with non-left bundle branch block morphology will not get any benefit from resynchronization therapy. And unfortunately, the current clinical practice lacks a validated selection criteria that may identify the possible responders in this subgroup of patients. So the CRT implantation in them is becoming increasingly controversial, and the clinical decision-making in those patients is often challenging. There are few studies with different designs that have proposed some other additive selection criteria to improve the prediction of response to the CRT in those patients with non-left bundle branch block morphology. From these studies, there is an evidence that the use of the more sophisticated echocardiographic desynchrony markers can aid in the selection of patients with non-left bundle branch block and who might get more benefit from the CRT. And it is important for the cardiologist to be aware of the defects of the current ECG selection criteria, and despite these criteria provides an evidence-based approach for selecting patients for the CRT, they do not necessarily guarantee that it is the most optimal strategy for patient selection. And recently, parameters obtained from the vector cardiography, such as QRS area, might show a potential to improve or overcome the defects of the conventional selection criteria of the ECG and improve the response prediction regardless of the morphology of the QRS complex. Recently, also, the anatomical mapping might help in improvement of this selection criteria by detecting areas of scarring and areas of late activation. Finally, how to use the different techniques to optimize the response to the CRT and get most of the benefit of it. We refer the CRT response to the modification of the natural history of heart failure progression. And as we have seen before, that defining the CRT response is so complex, and numerous endpoints have been used, including the functional class and the echocardiographic changes. So basically, the success of the cardiac resynchronization is dependent on, first, the appropriate selection of the patients. And this is fulfilled through proper selection of the patients according to the guidelines. This will include those who have ejection fraction of 35% or less, complete left bundle branch block with a QRS duration of more than 150 milliseconds, symptomatic heart failure despite the optimum medical treatment, and the need for frequent ventricular pacing. The second point of success for the resynchronization therapy is through the maximization of the left ventricular resynchronization. This would correct the delayed activation that is imposed by the conduction abnormality. And this is fulfilled by the appropriate lead positioning either in the posterior or posterolateral left ventricular wall, and preferably the base and not the apex, and preferably the site of the latest electrical activation of the left ventricle. The last point regarding the optimization of the resynchronization therapy is through the continuous delivery of biventricular pacing with every cardiac cycle to deliver the maximum dose of therapy. And this is fulfilled through the optimization of left ventricular capture, a true biventricular pacing of more than 95%, and rate control in atrial fibrillation, and we might need also AV nodal modification, and the treatment of frequent premature ventricular ectopics. The future directions for the improvement in the or the optimization of the resynchronization therapy include different imaging modalities and different pacing techniques we have discussed before in this lecture. The complications that have been described with the use of the cardiac implantable electric devices include, first, infections, which generally appear within a period of 2 weeks after implantation, but can manifest greater than 6 months after the procedure. The risk of infection is higher during battery replacement procedure than with the initial implants, and superficial infections can be treated with oral antibiotics only. However, deep pocket infections might require that the pacemaker and the leads be removed in conjunction with intravenous antibiotic therapy. The leads can fail over time because of insulation break and wire fracture, and when the leads fail, it might be necessary to extract the leads. Keeping the lead in place can be undesirable and might lead to venous occlusion and increased complexity of future extraction. There are now advances in both mechanical and laser lead extraction tools and have improved the success and safety of the lead extraction. But if the lead extraction remains a high risk procedure, you can leave it in place and insert another wire, especially in patients with old age. Pocket hematoma is a common postoperative complication, and usually it is small enough and would resolve without intervention. Rarely it might need evacuation, and sometimes it will need antibiotic treatment to prevent pocket infection. In rare cases, the placement of a pacemaker ICD lead can lead to cardiac perforation, and this can cause pericardial effusion with or without tamponade. The microperforations generally do not have any clinical impact, and the patient should be monitored for symptoms of pericardial effusion or tamponade. But in the cases of a slow leak, symptoms might develop after 24 or 48 hours after the procedure. And as we have mentioned before, those patients who have a high percentage of ventricular pacing, more than 40%, should be monitored for the development of pacemaker-induced cardiomyopathy. The exact entity or incidence of this entity is unknown, and the treatment is to upgrade the device to a biventricular device. Phrenic nerve stimulation is a common complication of pacemaker left ventricular leads, and less commonly with right atrial pacing. It is not harmful, but it can be quite bothering and intolerable for patients depending on its severity. There are some concerns related to the implantable devices. One of them is the pacemaker-mediated tachycardia, and we have discussed it in the first section on the pacemaker, and we discussed the methods how to prevent and treat this problem. In patients who are at the end of life, it's advisable to deactivate the ICD therapy to prevent the painful shocks and allow the patient to pass peacefully. However, this management can create some complex ethical dilemmas, and the Heart Rhythm Society has published an expert consensus document to assist in managing these situations. In the ICD, when applying a magnet, the magnet will deactivate all the therapies of the device, but it will not alter the pacing function. And when the magnet is removed, all the programmed therapies will be resumed again. This in contrast to pacemaker. When the magnet is applied over the pacemaker, it will result in switching to a non-sensing or asynchronous mode, and the continuous pacing will be at a fixed rate. When the magnet is removed, all the pacemaker functions will be resumed again. The potential risk with electromagnetic interference is of inhibiting the pacemaker or giving inappropriate ICD shocks. So bipolar pacing and the improved filtering in the modern devices had greatly decreased this risk of interference. And there is a little concern with the magnetic waves in the general activities of a daily living, like the one from the microwaves, which is no longer a concern, and the normal cellular phone use, which is safe, but it is recommended to keep the cell phone further than 8 centimeters from the pacemaker. The greatest potential for magnetic interference is within the medical environment, and this is through the electrocautery, which is a large source of electromagnetic interference, and the devices should be programmed for medical procedures using this electrocautery. Sometimes in hospital telemetry, the tracings can show what appears to be abnormal function of the pacemaker due to unexplained pacing rates or timings, and this can be explained by programming algorithms and timing sets in the pacemaker itself. And it is important to have this investigated with the full device interrogation to differentiate is it a true or a false or a malfunction. Regarding the different or the appropriate imaging with the patients with different devices, all the radiographic, computed tomography, mammography, and ultrasound imaging are safe. In the past, the presence of the electronic devices has been considered as a contraindication for MRI. But nowadays, there are MRI conditional pacemakers and leads have been developed and are available for implant. But also in case reviews and studies, there had been shown that it is safe to perform the MRI in non-MRI conditional devices, but this would be at a facility with appropriate guideline-directed protocols and management of these patients. Finally, the Heart Rhythm Society had published a statement on the MRI and radiation exposure in the patients with the implantable devices, and it was published in 2017. Now let us have a quick look on what is new in the era of pacing. The first of the new era of cardiac pacing is the leadless pacemaker. The subcutaneous pacemaker, although it is reliable and effective, the complications are almost due to the lead. This is because it is subjected to repetitive mechanical motion with each cardiac cycle and with the shoulder girdle that expose it to mechanical stress and fracture. The leadless systems has been developed using two distinct strategies, a single component and a multi-component systems. With a single component, the entire pacemaker, the battery, electronics, stimulating electrodes, and sensors are compressed into a small capsule that is delivered into the heart using a deflectable sheath. The advantage of this strategy include a greater energy efficiency, system simplicity, and ease of implantation. However, it has certain limitations that include the retrieval of the intracardiac system after battery depletion and uncertain thrombus infection risk. With a multi-component system, a small seed is placed within the cardiac chamber to act as an energy transducer, and a second extrathoracic component beams the energy, which is usually either an ultrasound or radio waves, to the seed, and this seed then converts this energy to a pacing pulse. The two available single-component leadless pacemakers are the NanoStem from St. Jude Medical and the Micra from Medtronic. Both systems are single-chamber rate-responsive pacemakers. The NanoStem actively fixes into the myocardium through a helix by screwing it, but the Micra system passively fixes into the myocardium through an inert nitinol tie-ins. The NanoStem system is smaller in diameter and has a larger battery that gives it a longer longevity. And this is in contrast to the Micra system, which has a larger diameter and a smaller battery with a shorter longevity, but it uses the auto capture technology so as to conserve energy. Regarding the telemetry connectivity, the NanoStem system has a conductive connectivity telemetry, and the Micra system has a radio frequency connectivity. Regarding the extraction, the NanoStem had developed removal tools for removal of the depleted battery, and it was successful in one study in 14 out of 15 removals. However, the Micra system did not have any tools for removal, and in one study, the removal was successful in 7 out of 9 attempts. In the analysis of the Micra study, the leadless pacemaker was associated with fewer short and intermediate term complications. This was mainly due to the reduction or absence of lead complications, infections, and pocket complications, and across all the leadless devices, the infections appear rare. This is due to the lack of the extravascular pocket that have a direct connection to the bloodstream. The major limitation of the current generation of the leadless pacemakers is the ability to only perform single-chamber ventricular pacing. So for most patients with sinus node dysfunction or sinus rhythm and AV block, dual-chamber transvenous devices are preferred. Also, in patients in need for resynchronization therapy, they are not candidates for single-component leadless pacemakers. Patients with inferior vena cava filters and the mechanical tricuspid valves also are not candidates. Device embolization has not been reported, but still remains a concern, and the accuracy of the rate-responsive features is not well understood. And as was noted earlier, the optimum management at the time of the battery depletion is not well known. Because of the lack of a surgical wound and the absence of arm restrictions after implantation and the reduced rate of complications, these leadless systems represent a paradigm shift that can be clinically transformative later on. And currently, dual chamber systems are under active development with design challenges, including device to device communication and fixation in the thin walled right atrium. The WISE CRT system uses a multi-component strategy to provide the leadless cardiac resynchronization. A small receiver electrode is placed endocardially in the left ventricle, and a subcutaneous pulse generator is placed in the left lateral thorax that generates ultrasound pulses which are converted to electrical pacing stimuli by the endocardial seed. All the patients in the WISE CRT study had a conventional pacemaker or a defibrillator. The subcutaneous WISE CRT pulse generator had detected the right ventricular pulse from the standard pacemaker, and this will trigger the endocardial left ventricular pacing. The initial trial included patients with failed coronary sinus lead placement, non-response to the CRT, or a need for an upgrade to CRT. And the data from small studies had demonstrated a significant QRS narrowing and a 5% absolute improvement in the ejection fraction, with improvement in the composite clinical scores at 6 months. The initial WISE CRT study had been stopped for safety reasons. 3 patients had developed pericardial effusions, and this was associated with the delivery of the seed. Following delivery system redesign, the data included another 14 patients and showed no implant-related adverse events. The leadless endocardial pacing is promising in that it might be more physiologic and afford a greater opportunity for left ventricular pacing site selection, will lead to the greater response to the CRT and lower risk of proarrhythmia, and also it will eliminate the phrenic nerve stimulation and reduce the risk of mitral insufficiency and lead-related complications. But this technology is still early in its development, and there are many unknowns for these devices. The challenges might include the identification of the acoustic window, the energy inefficiency, and the early battery depletion, the hazards of chronic sonification of the cardiac tissue, and the susceptibility to environmental interference. Other mechanisms for the two-stage leadless pacings are still under exploration. Preclinical experiments have performed using the magnetic induction rather than the ultrasound to derive an endocardial seed. And other multi-component leadless systems, including the integration of a subcutaneous ICD with a leadless pacemaker, are under development. This would allow for anti-bradycardia and anti-tachycardia pacing in conjunction with the subcutaneous ICD. In a certain population of failed conventional CRT, the SELECT LV trial had demonstrated that cardiac resynchronization with the endocardial left ventricular stimulation through the leadless pacing electrode was feasible and effective. And they demonstrated a high implant success rate and improvement in the heart failure clinical composite scores in about 85% of the patients, and a positive echocardiographic response to the CRT in 52% of the patients at 6 months. And on looking to this graph, the clinical outcomes of this study had been compared quite favorably to the clinical and the structural improvements that were observed in the conventional CRT trials. The subcutaneous ICD was developed to overcome the limitations of the transvenous systems, and in particular, the lead-related issues that can occur in up to 20% of the patients. The device has a pulse generator and a single electrode with 8 cm shock coil at the distal end. This shock coil is flanked by 2 sensing poles. The pulse generator is inserted under general anesthesia into the subcutaneous pocket at the left mid-axillary line at the 5th or 6th intercostal spaces. Then the electrode is tunneled subcutaneously from the pocket medially towards the xiphoid incision, and then going cranially up along the side of the sternum using 2 or 3 incision techniques. There are 3 sensing vectors in these subcutaneous ICDs: the primary, secondary, or the alternative. The primary vector is from the proximal sensing pole to the generator, the secondary from the distal sensing pole to the generator, and the alternative from the distal to the proximal sensing poles. If ventricular arrhythmias is detected, so the device will deliver an 80 joule shock, and this shock will be followed by bradycardia pacing at 50 beats per minute for up to 30 seconds. Up to 16% of the patients are found to be unsuitable for this subcutaneous ICD due to the inadequate sensing, so screening for suitability before implantation is mandatory. And this process involves collecting some modified ECG tracings that are taken in both the supine and the standing position to evaluate for adequate R to T wave ratio. And at least 1, but preferably 2, of the 3 sensing vectors should be acceptable in both positions for the implant to proceed. The most common cause of inappropriate shocks for this is due to the T-wave oversensing. Here in the effortless trial, the overall complication rate of the subcutaneous ICD was 4.1% at 30 days and about 8.4% at 1 year. The infection rate requiring device removal was higher in the first year. The results of the recent Praetorian trial that had presented in the Cardiac Rhythm News this year and will be published in the New England Journal of Medicine had demonstrated a non-inferiority of subcutaneous ICDs compared to the transvenous ones. It was a prospective randomized comparison of both systems with respect to the acute and long-term device-related complications and inappropriate shocks. Follow-up period reached up to 48 months. Patients were included if they are 18 years of age or older with a class 1 or 2A indication for ICD therapy for either primary or secondary prevention. And they were excluded if they have indication for pacing therapy, either for bradycardia, resynchronization therapy, or antitachycardia pacing, and also if they have failed subcutaneous ICD vector screening. It included more than 800 patients, and those patients were randomized to receive either a subcutaneous ICD or a transvenous ICD. Most of the patient population were males, about 80%, and their median age was about 63 years of age. The majority had ischemic cardiomyopathy with a median left ventricular ejection fraction of 30%. At 4 years follow-up, the primary endpoint of inappropriate shocks and complications occurred in 15.7% in the ICD arm and 15.1% in the subcutaneous ICD arm. And in the ICD arm, the inappropriate shocks occurred in 9.7% of the patients compared to 7.3% in the transvenous arm. And the main drive for the inappropriate shocks in the transvenous arm was atrial fibrillation and supraventricular tachycardia. However, in the subcutaneous ICD arm, the main drive for inappropriate shocks was oversensing. There was a lower rate of device-related complications recorded in the subcutaneous arm compared to the transvenous systems, and there were more infections in the transvenous ICD arm, but this was counterbalanced by more bleeding complications in the subcutaneous ICD arm. The major difference in the numbers of complications was caused by the lead-related complications, which was 1.4% in the subcutaneous ICD and 6.6% in the transvenous systems. And there was no significant difference in the mortality measured here in the trial. We know that battery depletion and pulse generator exchange represent a source of complications for the transvenous system, and carries also a risk in the leadless systems. The cardiac and the pulmonary motion can provide a big source of energy during the lifetime of a patient. So Piezoelectric nanowires have been deployed on a flexible device to generate voltages as large as 2 volts and currents up to 100 nanoampere. These were sufficient to power the microelectronics of a pacemaker. These motion harvesting pacemakers still remain in the field of research, although the devices have been built and tested in animal models. Another type of the batteryless pacing is the biological pacemaker, which modified the nano pacemaker myocytes to provide automaticity using gene therapy technology, or by adding a pacemaker synthetia to the heart through stem cell therapy. These biologic pacemakers are still in the early stages of development, and the current challenges include the difficulty ensuring the long-term engraftment and potential for proarrhythmias. So to summarize, pacemakers had evolved from simple devices that can prevent bradycardia to complex, highly programmable systems. And sudden cardiac death is a catastrophic result of the acquired and genetic heart diseases, with coronary artery disease being the most common cause in old age. Because of the suboptimal ability to define patients that are most likely to get benefit from the ICD, the development of better risk models is needed for the better stratification of those who are at high risk for sudden cardiac death. And cardiac resynchronization is an established mode of treatment of heart failure, but patient selection, optimization of response, and management of non-responders, multi-site left ventricular pacing remain areas of active investigations. His bundle pacing and leadless systems offer fundamental shifts in approach and potentially improve the clinical outcomes, and on the horizon may be batteryless pacemaker that transform mechanical motion into usable electric energy will provide a major advancement in the field of pacing.